Okay. Thanks a lot. Now we will discuss two cases in our MDT session about recurrent breast cancer. We'll start with the first case. First case is 34 years old female patient, married with no family history of breast cancer, no relevant medical history of any chronic illness, presented to our center in August 2022, complaining of left breast mass for 1 year. Initial clinical examination revealed the left upper outer quadrant suspicious mass measuring about 4 by 3 centimeters with palpable ipsilateral axillary lymphadenopathy.
She underwent bilateral sonomammography that revealed left breast upper outer quadrant suspicious mass with infiltrated ipsilateral axillary lymph node. So a core biopsy was taken.
الكور بايوبسي كان في infiltrative malignant neoplasm with very poor attempts of ductal formation. و again في high anaplasia, increased anaplasia و very poor attempts of ductal formation with prominent mitotic activity. والماركرز كانت weak ER weak nuclear reaction in 5% of tumor, score 3/8, PR 2/8, HER2 negative, almost triple negative. الdiagnosis invasive ductal grade 3, ER PR HER2 3/8 2/8 score 0.
So she underwent contrast-enhanced sonomammography that revealed left breast upper outer quadrant single malignant enhanced solid mass measuring 5.3 by 4.4 centimeter with ipsilateral pathological regional lymph node bias 6.
So I think we will ask Dr. Yes.
Why did you choose contrast enhanced, not MRI? For staging for this lesion. ليه بقى؟ لأن أنا شايفة هي she's young, dense breast. يعني I would do in this case MRI يعني more sensitive to stage any small.
Yesterday you told us that MRI is to solve a problem, not to diagnose. But here there was not a problem. We just wanted to get a clearer picture.
Yes.
But this is another story. This case, you are doing staging. It is already known it is a malignant. So if there is any internal mammary node or deeply seated level of axillary node in the lip. Yes, it is for staging.
So it read yesterday that MRI is to solve a problem, but
no
staging, but not to diagnose.
Yeah, yesterday was a papilloma or a lesion that's anyway it will enhance. So it's not solving. It's benign or malignant. It doesn't solve it. It's staging. But here, yes. I'm concerned about any small satellites. Any.
I think we as a surgeon prefer usually the contrast mammogram. It's very clear to us to show the delineation of the lesions and speculations rather than the MRI. But we get our message from the contrast mammogram, and I think you usually go for MRI in the deeply seated lesions and the inframammary fold lesions, and so I think this lesion can just was upper outer quadrant lesion. So the image of the contrast give us a clear picture.
بعد البيكتشر دي of the contrast enhanced mammography, would you need an MRI? For I know يعني لو هي الصورة دي بالنسبة لنا واضحة جدا مش محتاجين تاني MRI.
طيب نكمل.
Her metastatic workup revealed no distant metastasis.
MDT dissection was for clapping, then neoadjuvant chemotherapy followed by left-wide local excision and axillary clearance. So
can I ask about the tumor size in the contrast mammogram and while we are taking a decision for neoadjuvant, the tumor size, the contrast, it's about. Yes. Okay. Dr. Kopiker, have a comment?
First of all, I think contrast enhanced mammography has shown nearly equal sensitivity to MRI. And the second is its false positivity is much lower. You have a 93% positive prediction value for contrast mammography as against a 60% for MRI. So I would always prefer a contrast mammogram. What question I want to ask is there a little bit of non-mass enhancement in that? On the extending to the medial side into the central part of the left breast? It is a little bit more evident on the AP view rather than in the oblique.
There was no enhancement, no regional enhancement around the lesion, and there is no intraductal extension. It was a single malignant enhanced solid lesion without any other enhancing areas.
Yeah, I think there is bilateral background enhancement in general in both breasts. The lesion is single with the contrast enhancement. So my question is about the tumor size and the nodal positivity that necessitate the start of neoadjuvant approach.
I don't want to leave the X-ray people yet. No, okay. No, I'm sorry. Somebody raised a question. No, what we mean? How soon for our practice can we get a contrast after a core biopsy? No problem. Because sometimes we do send it for contrast and they say, no, she's had a core biopsy 2 days ago and we cannot do it. We have to delay it 2 days. So we can delay it for 2 days. Yeah. So, would you consider these post biopsy changes? This non-mass enhancement around?
I think the non-mass is in bilateral, Dr. Ashraf. So it is bilateral background enhancement. So it's apart from the enhancement of the lesion itself. Yes. Yes. So.
Yani, I have a comment about this aggressive tumor in young lady, 34 years old, with locally advanced breast cancer, with axillary lymph node enlargement. Did you have any genetic profiling for this? And the triple negative, of course.
Almost triple negative, and we discussed this issue yesterday about the BRCA indication, BRCA gene testing indication, also, especially in the young women with almost triple negative. So it is a little bit indicated or not. It's discussed thoroughly yesterday. It's a very important issue. So what's next?
So patient received neoadjuvant chemotherapy for AC for 4 cycles, then followed by.
أنا بس هسأل عشان حكاية التريبل نيجاتيف ولا مش تريبل نيجاتيف. Would you consider a patient with ER 5% and BR I think 1%? It's 2/8. It's not more than 2 or 3% as a triple negative disease or still a luminal B disease?
I mean, we would treat it as a triple negative disease.
Yeah, and from
with the last guideline, it's not triple negative. Triple negative by guidelines, 1% to 9% is low ER/BR, but you cannot say it's triple negative. Some oncologists treat it as triple negative, but 3/8 should be low ER.
yeah, so exactly. So it's low ER because it's 5%, so up to 9%. But these can be, for management purpose, managed as triple negative breast cancer because they are low ER. Yeah.
It's not included in any trial of triple negative. All the trials of triple negative based on 1% and above.
But in the decision making,
less than 1%.
Yeah.
All the trials. We don't have a recent trial addressing the patient 1 to 9%. All the others is not included yet.
But as a decision making in the treatment wise, it will be treated with neoadjuvant first.
No doubt, these patients behave like triple negative.
Yes.
Although data from Keynote 522, they enroll patients with ER negative tumors, but in the expert opinion and many for further guidelines, they are treated those patients as triple negative behavior because she has a large tumor She have a nodal burden. She has a young age and grade 3 tumor. So by any way, we are going to give her keynote 522 pembro plus chemotherapy.
Okay. So, Dr. Reda,
She's
we have a comment from Dr. Reda.
Hormone therapy.
Now, I want to comment about the clipping. They did clip of the mass. Did they clip the lymph node? Multiple. Because this is an exceptional responder. I am expecting that it will give complete radiological response. So I would like to clip the most significant accessible lymph node in the axilla. I would prefer that.
It's a very important point about can we go for clipping of the pathological axillary lymph node, but they mentioned this multiple pathological axillary lymph nodes. So I think we don't go for clipping for this point. And so, Dr. Kopiker.
So, how many nodes? I mean, multiple means how many nodes were there? If it is still N1, if it is multiple clinically N1 non-matted nodes, you can still clip the most prominent node. If you do TAD usually in your unit, if not, you don't do it because you really there is no difference within sentinel node and TAD really.
Actually, we go for TAD excision of the positive lymph node if they're less than 3 lymph nodes. So we will clip the positive 1 or 2 lymph nodes. But I think in this case it was more than.
Just another practical point here about the clipping. Do we clip from the very beginning, or we give the first and second dose, and then if they are fast responding, we put it? Because some of them do not respond very well, and we can say spare them the clip.
We clip from the start. This is her best chance before starting chemotherapy because chemotherapy induces some changes in the vascular channel. So the one which is more at the start as a sentinel lymph node might be changed, and another one will be the sentinel because of changing the vascular. The main tumor or the lymph node? The main tumor, yeah, if we can wait, but we are speaking the patient.
يلا دكتورة بسمة.
Patient received neoadjuvant chemotherapy, 4 cycles of EC followed by 4 cycles of Taxol carboplatin, then referred to left wide local excision and axillary clearance.
At the end of the neoadjuvant therapy, a radiological complete response was revealed, so a wire was inserted over the clip.
Left wide local excision and axillary clearance was done on 13 March 2022.
السبيسيمن shows انه في residual viable tumor. However, الviability كانت قليله قوي, almost يعني 2 to 3%. Again في treatment effect related للtumor, في surrounding fibrosis وهيلينوسيس, والtumor نفسه في treatment effect. الليمف نودز كانت negative 0/21. However, more than approximately 4-5 فيهم therapy response, بس complete therapy response. فالفاينل diagnosis residual invasive duct carcinoma grade 3 stage YPT1A and 0. Treatment effect cellularity around 2% RCB1. Margins free, lymph node 0 على 21 with therapy effect.
So, in conclusion, regarding case timeline, MDT decision for clipping the neoadjuvant followed by left wide local and axillary clearance. Patient received neoadjuvant chemotherapy followed by contrast sonomamo that showed complete radiological response. Then left wire localization of the clip and wide local excision and axillary clearance was done, followed by the adjuvant treatment.
As patient wasn't incomplete.
One question. With the patient with the T1A post neoadjuvant, would you consider capecitabine?
Ask before regarding the BRCA mutation, as my friend said. The decision of surgery can be affected by the result of BRCA. يعني
يعني انتوا you labeled her as triple negative, right? Why she was given tamoxifen? because triple negative, and CR whether triple negative or luminal A, there is no role of adjuvant chemotherapy after because she's achieved complete response.
يمكن نفس الكلام زي ما دكتور جمال بيقول احنا اتعاملنا على انها تريبل نيجاتيف وبالتالي we considered capecitabine because she is T1A but again we give adjuvant tamoxifen so she is triple negative or hormone receptor positive.
هي اتعاملت على تريبل نيجاتيف عشان لو اي ار وبي ار واحنا يعني I do believe in the patients with ER less than 10% or 1 to 9 they are behaving like triple negative. But again we have a report that the patients with low ER they get benefit from the endocrinal treatment. That's why we try to give her the benefit of the both drugs. She's young, she has an aggressive. I should give her everything I know to just يعني to receive the best treatment options. ما هو ده اللي انا بساله يا دكتور جمال. هي she is
I understand tamoxifen and I believe I will get tamoxifen. But why Zeloda after complete response?
This is not a complete response. هي T1 ما هو ده السؤال ما احنا هنختلف. T1A this could be considered as complete response or not a complete response. Still there is a viability يعني الفكرة. زي بالظبط ال HER2 positive بعد النيو ادجوانت لو فضل T1A still there is a rule for TGM1. فده السؤال.
I agree for capecitabine keeping with CREAT-X trial في 2019 but still this is a triple negative patients. She will gain no benefit of adding tamoxifen. If you are adding something of hormonal treatment, you should add also ovarian suppression, not tamoxifen alone. But she is triple negative. Okay.
The Softotex trial included patients with 10% and more. For 5% to receive hormonal treatment, we can give tamoxifen as single agent. وخصوصا ان I know that the response is not that good to the endocrine and such low ER and PR, but still there is a benefit as I think it was published in ASCO 1 year or 2 years. Those with low ER and PR still get a benefit from endocrinal treatment. Low endocrinal is defined as less than 10%. دي المشكلة.
Can I ask the pathologist about the repetition of ER in this situation post neoadjuvant chemotherapy? Is there a rule to repeat ER or BR in this clinical case scenario?
Yeah, so in general, we do repeat on any residual disease. It's not mandated in all the guidelines. So the UK guidelines do not mandate it, but there is a lot of evidence in the literature that particularly conversion from negative to positive can be beneficial. So a tumor moving from ER negative to ER positive might give a new option. And particularly, I think in this one, because it was ER low, I would report it. Also, HER2 negative to positive. So although it's not mandatory in CAP guidelines, they do repeat. In the UK guidelines, you can, but it's not mandated.
With the good response of the patient, would you think that the patient is from ER negative to ER positive because the patient has an excellent response like the triple negative? So I don't think should repeat only also after this very marvelous response. Do you think it's important?
Yeah, that's excellent response. That's what we call minimal residual disease. That's very little. But in this context, if it turns out to be strongly positive for ER, that would be more of a case to give tamoxifen therapy, to give endocrine therapy. And again, some tumors move from HER2 negative to positive after treatment. So you would have, and some evidence in the literature suggests that this might be prognostic as well. So tumors that move from ER negative to positive do better than the other way around. So I think that there is, although it's not mandated, it gives you a bit more information and maybe more options of treatment that otherwise wouldn't be given if not treated.
So I think we have a short of time, about 10 minutes and till now we don't reach the recurrence.
Quick comment
so
about
I think
a comparison of core biopsy versus tissue biopsy after postoperative. Our pathologist told us that ER-BR will be more accurate in the core biopsy rather than the whole biopsy. I didn't understand that, but they what he said, and I think there's debate about you doing ERBR on the whole core or on the post-operative pathology.
I think it's to do with the fixation, with the fixation rather than which is better. For the penetration of the formalin, to my understanding, for a core biopsy would be very quick, while it might be a bit delayed for the specimen. I'm getting into not my territory.
So this.
If I'm trusting in the fixation process after excision, if I'm dealing with a fresh tissue in an institute or in a qualified or accredited lab, I'm sure that the cold ischemia time is not exceeded. So I'm trusting the excision biopsy more than the biopsy because of heterogeneity of tumors in core biopsy is frequently reported as heterogeneous tumors in ER and PR and HER2 also. So excision biopsy or excision specimen can give us more detailed about the status of ER, PR, and HER2. In the setting of this case, we are routinely repeat ER and PR on all triple negative, strictly triple negative 0 out of 8. We are repeating ER and PR. While in this case, in this viability 2% and low ER and PR, it's not our alone decision. If MDT asked for repetition, we are doing this repetition without hesitation. But we are not doing it routinely if it was ER and PR low and giving a good therapy response to 2% viability.
So I think we have to move to the what's next in the patient because we have 8 minutes about on.
During her annual sonomammography that was on August 2025, a left upper outer quadrant highly suspicious soft tissue lesion, likely a recurrence, measuring about 1.5 by 1.7 centimeter with no pathological axillary lymphadenopathy.
Clinical examination revealed left upper outer quadrant 1 o'clock mass measuring about 2.5 by 3.5 centimeters with no skin affection or palpable lymphadenopathy.
So a core biopsy was taken from the lesion.
The biopsy shows extensively necrotizing poorly differentiated tumor. We, again, very poor attempts of duct formation with very high anaplasia with extensive mitotic figures. البايوماركرز ما اتغيرتش كتير. ال ER 3/8 PR 2/8 less than 1% here 2 negative. فالdiagnosis can extensively necrotizing invasive duct carcinoma grade 3 recurrent, ER PR low positive negative and HER2 negative.
During her metastatic workup, a small segment 2 and 6 hepatic focal lesion was revealed that's confirmed by MRI to be cysts. So she underwent contrast enhanced MRI that revealed left breast upper outer quadrant operative bed recurrent malignant single lesion measuring about 2.5 by 2 centimeter, pathologically proven IDC by 6.
So in such a case, isolated locoregional recurrent breast cancer triple negative, how to treat this patient for upfront surgery versus neoadjuvant treatment, especially in the era of immunotherapy today?
Dr. Muhammad, and go for neoadjuvant ولا go for surgery?
قبل ما اقول في neoadjuvant انا عندي رساله صغيره بس. الحالات اولا دي لولو بوزيتيف ER should be categorized not as triple negative. It will be dealt with as triple negative. From a surgeon perspective لا انا هقول دي atypical triple negative. الحاجة التانية مفيش ماس T3 to be changed to T1 واحط فيها كليب. حط 3 كليبس اتليست على المارجن بتاع ال5 سم لان انا مش هشيل الواير والاونلي اريا دي. I will remove wide local excision upon the original mass. Removing the cytoreduced mass is accepted in T2 not in T3. In T3 I will remove the whole area. ده الكومنت الاولاني على الحالة الاولانية. الحاجة التانية I will know التريتمنت افكت على الليمف نودز، انا مش عايز اقول 0 على 21 ليمف نودز، هل كان في عندي كام ليمف نود فيها تريتمنت افكت وكام؟
كان في
كان
almost
في
4
treatment
فيهم
effect.
ثيرابي افكت. almost 4 فيهم ثيرابي
اوكي
افكت.
ده الجزء الاول. الجزء الثاني طبعا انا بتكلم دلوقتي على ميتاستاتيك ريكارنت كانسر بريست. قلت فوكال ليجنز.
liver MRI is clear.
ايوه دلوقتي كان في هيباتيك فوكال ليجنز وسيستيك نيتشر
MRI is
they are
clear.
proved benign. طبعا انا I will go for biopsy of these liver masses, biopsy and adjuvant therapy بلا شك.
So from the surgeon perspective, we will start new adjuvant therapy again for the recurrence.
رأي الميديكال انكولوجيست.
I usually, if I decide I should go to the guidelines and clinical trials. This is just a moment. This is a recurrent disease, not primary disease. The study of triple negative based on primary breast cancer, not recurrence. Recurrent breast cancer is something else. There is, in my opinion, there is no role of neoadjuvant chemotherapy in local recurrence if the disease is operable. The only treatment of patient with recurrent disease is the standard of care is salvage mastectomy, except in some certain positions you can thinking about giving second excision and breast conservative, doing local excision with partial breast irradiation, giving excision plus interstitial brachytherapy. But in this patient, this is not a new patient. This is recurrent disease. We don't have in our trials or guidelines to treat any recurrent patient with chemotherapy if the patient is operable.
As we are running out of time, can I vote how many of you would go for surgery before any therapy? And how many would go for systemic therapy first before surgery? Well, we're almost equal.
Can I have another question, Ashraf? Dr. Ashraf, can we re-irradiate again so we can go for surgery as a conservation or a mastectomy? The re-irradiation of the previously irradiated breast.
واحنا محتاجين نعرف الديتيلز اوف راديو ثيرابي الانيشال راديشن اللي خدت، هل خدت بوست ولا ما خدتش، هل اكزيلري راديشن ولا لا، الدوز اللي خدتها والبروتوكول اللي خدته، لان الري راديشن in a setting of reconservative is very difficult. اولا لازم ما يكونش فيه سايد افكتس من الراديشن الاولاني، وشكل البريست هنا في سايد افكتس واضحه. النقطه الثانيه ان انت يكون عندك الاوبشنز اوف ري irradiation باي لوكالايزد بريست irradiation، وفي الغالب ما عندكش التفاصيل، ما عندكش الا الاكسترنال بيم irradiation، لا في براكي ثيرابي ولا في ماموسايت ولا انترا بيم ولا انترا اوبرتيف. فانت الري irradiation في السكند بريست كونزرفاتيف بوزيشن لازم يكون بلوكالايزد وما يكونش اكسترنال بيم، يكون لوكالايزد مش اكسترنال بيم عشان يقلل السايد افكت اللي هتحصل. ده
If we can re-irradiate again, so we can go for conservative again in a certain criteria for the patients. So what's next, Islam?
BDL1 to be done or not in this case. There is possibility of getting pregnant after recurrence.
I think what's next in the case? What's happened in the case? Not this is the final
line of agent
this is the final slide for you.
لا.
So I think we are presenting this case because we have to ask about many points in the recurrence, so starting with neoadjuvant or not, and still there is a debate to start with neoadjuvant or go for surgery. And about the surgery, we go for conservative again or their completion of the mastectomy, which is the standard of care, and the criteria of selection of the patient for reconservation again. It's not in this case. So I think we have to focus about the most important criteria in reconservation and the recurrent breast cancer. I think in luminal A patients with small lesions, more maybe early T2 lesions with more than 3 years of recurrence, or maybe sometimes in 5 years. So it's not in the criteria of this case. So Dr. Rahman, you have a final comment about it?
If we have an access to the immune therapy دلوقتي ما خدتش immune therapy في الأول, and we know that the neoadjuvant immune therapy is effective while the adjuvant immune therapy is not that effective, are you still in your opinion you have to go to upfront surgery?
هرد على السؤال دوت. احنا بنتكلم على locally recurrence triple negative exposed previously to chemotherapy. Total neoadjuvant biology from the primary treatment than the recurrence. So I will go for PD-1 expression by CPS score to C3. If more than 10%, I will go for immunotherapy plus chemotherapy. If less than 10%, I will not give immunotherapy.
Do you have any clinical trial to support your treatment? The trial mainly on primary or not recurrent. The other one, metastatic, for metastatic triple negative breast, not local recurrence. Local recurrence, the treatment is surgery plus adjuvant, not adjuvant, plus systemic chemotherapy, but not immunotherapy in a locally recurrent disease.
What are you going to do for this case? Final. So we go for surgery and then we consider capecitabine.
What type of surgery? Mastectomy or reconservation?
Yeah. So we go for a mastectomy. Reconstruction, we will leave it to the surgeon because she's had previous radiotherapy. Complication of surgery will be there, but we have to conclude now and move on. Maher?
So I think the final decision is to go for surgery, and surgery will be almost mastectomy and then adjuvant systemic treatment in this clinical case scenario. I think we have a radiology final comment about the clipping of the three clips.
Aside from treatment يعني بس في two very important points here need to be addressed. The first, the clip, whatever size of the cancer, we put only one clip. Then post-clipping mammogram, where I can guide the surgeon after the treatment. What was the extent? Was the clip in the posterior aspect of the mass? Was it in the deep part? This is how I guide the surgeon, even if it's been respond. So I know from the initial start where's the clip located from the mass. This is your answer for your question about why we put at the initial set. The second thing, MRI contrast. If you look at the program of this conference, you will see a whole workshop about when to request contrast, when to request MRI. So I would appreciate much if our surgeon and chemo just discuss with the radiologist case by case, because it's not a rule that it's contrast enhanced.
Thank you very much. Thank you very much.
So the final decision is to combination mastectomy and the adjuvant systemic treatment. So we'll shift to the next case. Thank you. Dr. Yasmin. So the next case today will be about the visceral nodal bony oligometastatic breast cancer, the dilemma of oligometastatic breast cancer. Our presenter will be Dr. Sumaya Adam, Dr. Isra Asmat, Dr. Yasmin Hani, Dr. Basma Diab. Usually the oligometastatic dilemma, but in this case scenario, we'll show many cases about the oligovisceral or oligobony or oligonodal disease.
53 years old female, married with 3 offspring, post-menopausal,
قبل المايك شوية اسمه.
with no family history of breast cancer. Presented to Baheya Hospital in October 2025, complaining of right breast mass 6 months ago. Patient has history of recently diagnosed endometrial carcinoma outside Baheya.
The patient was studied with contrast-enhanced sonomammography and complementary ultrasound, and this is the 2D images of the mammography. The contrast-enhanced sonomammography images revealed a right breast upper outer quadrant, upper inner quadrant, and retroareolar ill-defined area of marked heterogeneous non-mass enhancement. Complementary ultrasound revealed an ill-defined area of altered parenchymal echogenicity mounting to large mass formation with internal abnormal vascularity. While the complementary ultrasound of the axilla revealed multiple pathological right axillary, infraclavicular, and supraclavicular pathological lymph nodes showing diffuse cortical thickening and some showing effaced hilum. So core biopsies from the breast lesion was taken, and this revealed
moderately anaplastic infiltrative tumor والاركيتكتشر بتاعته كانت single filing والlobular carcinoma يعني الماركرز ER 8/8 strong diffuse positive ال PR moderate staining in 5% of tumor cells 4/8 HER2 negative score 0 فالdiagnosis invasive lobular carcinoma grade 2 ER PR positive HER2 negative. ماشي الاندوميتريال بايوبسي بقى اللي كانت متشخصه بره سلايد ريفيو. هو بتاع ده بيعمل اوكي في endometrial glands وفي intervening abnormal infiltrate. on higher power intervening abnormal infiltrate ده كان فيه زي foci of هو more or less round cell infiltrate وفي حتت كده signet ring appearance و dissecting through the endometrial glands. cytokeratin كان diffuse positive. CD10 to rule out endometrial stromal tumor can negative. GATA3 strong diffuse positive, supportive of breast origin. ER positive. KI67 around 12-15%.
So Dr. Abir, you have to add any markers apart from this whole panel of markers?
No, I think it's a lovely case of showing that it's exactly the profile of the breast tumor. So this, that's exactly what I would do. You could do EC-adherent, but it's actually in this case, it's not. So it looks like metastatic invasive lobular carcinoma in a polypoid, in a polyp in the endometrium. Beautiful.
Yeah, I think we exhausted all the markers at Hazem department to reach the final pathology, that's the CK and the GATA3 and the CD10, KI and the
ER.
DR.
Diagnosis metastatic carcinoma consistent with a breast primary, CK GATA3 positive, CD10 negative, KI around 15%.
Okay, the patient performed the staging study by post-contrast CT chest, abdomen, and pelvis, which confirmed the presence of the upper outer quadrant mass lesion with pathological axillary lymph nodes. The CT chest revealed the right lower lobe, lateral segment left and left lung periphyseal nodule. With these nodules were about 8 millimeters, and they are indeterminate nodules. The tiny hypodense non-enhancing pancreatic tail cyst, and another tiny non-enhancing also hypodense hepatic cyst seen at segment 2. The CT also showed the presence of bilobar hypoenhancing thyroid gland nodules. Thyroid ultrasound was done, which showed homogeneous parenchymal echogenicity of the thyroid glands with scattered tiny cysts.
As a summary, 53 years old female patient diagnosed oligometastatic right breast cancer to endometrium. Histopathology revealed invasive lobular carcinoma grade 2, ER 8/8, BR 7/8, HER2 score 0. So the question here, how to treat this patient? Should we treat patient with palliative intent or curative intent? And if we decided to treat patient with curative intent, should we start treatment with neoadjuvant therapy or surgery, upfront surgery?
Who wants to comment?
First of all,
a big fight now.
No. This patient also has lung metastasis, right?
Single.
There was a nodule in the lung.
It was an indeterminate nodule for follow-up.
But this is 1 centimeter.
Sub-centimeter.
It is sub-centimetric.
Sorry?
It is sub-centimetric. It was not 1 centimeter. It was
It's 1 centimeter, right?
Sub-centimeter.
The lung mass.
It was 8 millimeters.
So would you consider this is metastatic or this is equivocal?
It was equivocal for follow-up.
If it's equivocal, I may order PET scan, maybe will help. Although it's 8 millimeter, but it can help A PET scan sometimes between 6 millimeter can diagnose the case sometimes. But this is oligometastatic. The term of oligometastatic in breast is something between 1 to 3 sites, and usually if there's only 2 sites, not more than 2 sites. So now you have endometrium and breast, right?
Yes.
Decision is difficult here because we don't have any data in the management, and especially in breast cancer. We have data, very solid data on oligometastatic in cancer prostate. We have very solid data and more in cancer colon. In cancer colon, if you have cancer colon with liver metastasis, 5-year survival approaching 50% if you do metastatectomy. In these particular patients, I will forget about I will treat it radically, because even if I did surgery to the endometrium, it's not difficult. It's not a major issue. The problem here to have to settle the lung and the liver. If they are negative, both of them, I will treat her radically like any patient without metastasis. This is my opinion. Maybe it's not right, but we'll see
And
different.
we just remind she is a lobular, invasive lobular carcinoma. Yeah,
Well-
just for your therapy.
Actually, because if I consider the uterus as the only site of metastasis, I may go for surgery for both sites as Dr. Gamal suggests.
بس she has infra اماني. She has في infra and supraclav. She is locally advanced. Systemic therapy for surgery. Systemic therapy, then assessment. If CR, we go for surgery for both.
Just a comment. Yeah, I hear also it's better to use Taxol Carbo as well in the chemotherapy regimen.
For you
Amani,
as
I think,
a medical oncologist, again, does the word invasive lobular carcinoma affect your type of chemotherapy? No.
Dr. Ashraf, I have one opinion, please, because we have a definition now that we have dealing with patients with TNM staging by metastatic breast cancer of lower primary, M1 disease, N3C, because I have paraclav, supra and infraclav. She go for any way to receive systemic control optimally by hormonal treatment, not by chemotherapy, by letrozole plus CD46 inhibitor, especially ribociclib, because they have a strong data to have a good control for such patients. Don't forget that patients have a metastatic disease to the endometrium. It's a very classic way of lower subtype. So don't forget this patient needs a systemic good control.
But systemic chemo or hormone?
Hormonal treatment.
With
If the patient have a good response, you may change your mind towards surgery, but no surgery for this case.
But I mean, the type of systemic therapy being lobular, as you said.
All the
push you
guidelines.
towards she's postmenopausal, she's
Yes.
ER positive, invasive lobular carcinoma. Would you go
Yes.
for chemotherapy?
No chemotherapy.
Or hormone plus.
No chemotherapy, Dr. Ashraf, for this case, because this is a M1 disease. She received CD46 inhibitors plus letrozole by all guidelines.
I agree with Dr. Muhammad, but this is a special case. Here you need very rapid response to achieve complete response, so you can go for surgery if you believe in surgery. CDK4/6, yes, I agree with you, very effective, but not in the local control of the breast itself. It's very good in overall survival as well as in the progression-free survival. So in this particular case, I extrapolate from the trials in the breast cancer that I will give neoadjuvant chemotherapy, followed by, if they achieved a very good response, followed by surgery to the breast and the endometrium, followed by adjuvant hormonal plus CDK4/6. Here, like extrapolate from the Baheya Monarch E, and giving this will take good treatment without too much side effects.
من السيرجنز بس ايديا، يعني بنهتم في الميتنجز دي نقول لحضراتكم السيرجنز فكروا ازاي. حلو قوي هنتعالج بكيموثيرابي ولا هرمونال ثيرابي، جميل. احنا بنفكر ازاي؟ الحاله دي الاول انا عايز احطها ايه؟ هل هي دي نوفو اوليجو ميتاستاتيك بريست كانسر ولا لا؟ I should pay every attempt ان انا اشخصها كويس بالبيت سي تي. اي سسبشن ليجن اي ويل بايبسي ات. هتفرق معايا جدا. انا عندي كام وان سايد؟ انا عندي كده تو سايدز اوف ميتاسيس. الاندوميتريوم and supraclav. Okay, we'll say it oligometastatic. بعد ما اديها induction chemotherapy انا خلاص my decision as a surgeon I will give her systemic chemotherapy. هتفرق معايا بعد ما اخلص systemic therapy whatever هرمونال اور كيمو. بعد في الاخر خالص بقى انا هعملها على دونوفو اوليجو ميتاستاتيك ولا نوت اوليجو ميتاستاتيك and massively metastatic عشان اعرف بعد السيستميك كيموثيرابي هاخد ولا لا. I should go on for كل الانفستيجيشنز to prove are there other metastatic sites ولا لا. نمرة 2 بعد ما تاخد لو هي فعلا اوليجو ميتاستاتيك دونوفو اوليجو ميتاستاتيك بعد systemic therapy I will do surgery for her.
Any other comment here? Dr. Amani. We want to hear from Dr. Amani and Dr. Wakil. Okay.
والحقيقه الليجن اللي كان باين في اللنج بالنسبه لي انا شكله اكتر من 1 سم، يعني انا استغربت لما قلنا ان الليجن 8 مللي، يعني اللي في الصوره نفسها ما يمشيش ان هو اقل من 1 سم.
عادة في حالات الاولجوميتاستاتيك بنجو فور بيت سي تي الاول عشان نتاكد ان قبل ما ادي اي تريتمنت ده فعلا حاضر فعلا بنعمل بيت سي تي، وقبل ما بندخلها العمليات حتى لو فيري جود ريسبونس وي ريبيت ذا بيت سي تي جاست تو بي شور ذات ذير از نو نيو ميتاستاتيك سايت. فذيس از ذا usual to give I consider this patient
one of the pitfalls of PET CT is to have a lobular subtype because low FG avidity for this subtype. By this small lesion of lung is a classic pulmonary nodules, not subpleural or subcentimetric. It's a classic pulmonary nodules. Keeping with endometrial metastasis, it's a formally metastatic lobular carcinoma to the serosal and the uterine and pulmonary. So and paraclav also. So the systemic control is there. Yes, not illegal. Not illegal.
We will present another case. A 48 years old female married with 3 offspring, premenopausal, hypertensive with no family history of breast cancer, presented to Baheya Center in October 2025, complaining of left axillary pain. By examination, no mass felt in the left breast, but matted axillary lymph node in large size breast.
Okay, the patient was studied with sonomammography, 3D tomosynthesis, and complementary ultrasound. And this is the 2D mammography images. Okay, this is the tomosynthesis, which showed the left upper outer quadrant architectural distortion with overlying pleomorphic microcalcification. Another group of linear amorphous microcalcification was also depicted in the left paraareolar region. Complementary ultrasound was done, which revealed the presence of a left upper outer quadrant axillary tail, irregular shaped and vertically oriented hypoechoic solid mass lesion with anterior duct extension. No masses was seen underlying the retroareolar calcifications. Complementary ultrasound of the axilla also revealed pathological axillary level 1, 2, and 3 supraclavicular lymph nodes with other 2 posterior cervical lymph nodes that also showed pathological criteria with diffuse cortical thickening and some showing effaced hyla. So dynamic MRI of the breast was done, which showed the left upper outer quadrant deeply seated irregular shaped moderately enhancing mass lesion with that elicited low T1 and T2 with high stir signal and also restricted diffusion. No abnormal enhancement underlying the supraareolar calcification was depicted. On plotting the time intensity curve, such lesion also showed a type 3 curve. So core biopsies was taken from the left breast 2 o'clock lesion, and the left breast supraareolar stereotactic biopsy was also done.
Left breast 2 o'clock lesion shows invasive carcinoma of moderate anaplasia. شوية منهم عاملين ducts، شوية منهم فيهم lobular differentiation. biomarker profile بتاعها ER strong diffuse positive 8/8, PR 8/8, HER2 negative score 0. diagnosis كان invasive duct carcinoma with lobular differentiation grade 2, ER 8/8, PR 8/8, HER2 negative score 0. والبيوبسي الثانية left breast supraareolar stereotactic guided biopsy كان فيها fibroadenosis no malignancy.
Okay, the staging study was done, and this was done by PET-CT, which Also confirmed the presence of the left breast upper outer quadrant metabolically active malignant lesion, and also the presence of the multiple left axillary and supraclavicular nodal deposits. It also showed the presence of the FDG, low-grade metabolically active left posterior triangle lymph nodes, and it recommended fine needle aspiration. So no other metabolically active sizable distant metastatic deposits was seen. So the left posterior triangle lymph node fine needle aspiration was done.
Would you لحظة واحدة معلش يا جماعة. Would you go for fine needle aspiration ولا true cut biopsy أحسن من غير axillary من posterior triangle?
Right. So in the UK, we always prefer to core biopsy because you have tissue, you can do immunos, and it's easier. However, our radiologist, it depends on actually the radiology colleague. Some prefer FNA because it's quicker and easier, and it gives almost similar results. So in the UK, it's almost 50-50. What do you do? Core. Yeah.
If you have axillary lymph node, one, and you haven't anything in the breast like occult, sure you will go for true cut biopsy. Depend on what you want to know from this biopsy. Just you want, it is a metastatic, it's okay. We can go for fine needle if you are a good one who know how to take the cells to be satisfied for the pathologist. So it is enough. You want one answer. It is metastatic or not. So this case, what you are going to do, you will go to take, always we have multiple lymph nodes, so you will go for the supraclav, not the axillary lymph node, pathologically very clear by radiology. If you have one thing to do, go for FNA for the supraclav. I think it is enough for the oncologist to take decision about the treatment.
الفاين نيدل اسبريشن كان في malignant clusters of cells في السيل بلوك فوق هنا وال السميرز كانت برضو فيها المالجنت clusters of these cells فيها pleomorphism وهي INC ratio. GATA3 was positive confirming breast primary والحالة دي اتعمل عليها biomarkers على السيل بلوك. ER negative reaction, PR negative reaction, HER2 negative reaction. فالdiagnosis positive for metastatic carcinoma of breast primary, ER, PR, HER2 negative reactions.
The initial biological behavior for this tumor was
positive, positive.
But the metastatic showed ER negative, PR negative, HER2 negative. GATA3 was strongly positive, so there is some sort of activity of these cells. However, in view of change in behavior, this is an indication for us not to rely only on fine needle aspiration, as there is some factors that may affect the reactivity of hormones, such as fixation or scantiness of the tissue or the cells in the cell block. In this, and this will make a major decision for the patient. The patient is posterior cervical, so it's metastatic, not only for staging in axillary lymph node. So by communication with radiologists and the clinicians, we will ask for a true cut biopsy to confirm the diagnosis. If possible, if positive, it's positive. But if negative, no, I want to make sure this is a true negativity, not for other reasons. So I will ask for a true cut biopsy.
So
we are totally agreeing.
True cut biopsy.
Static workup and positive. Yeah.
So patient underwent true cut biopsy from left posterior triangle lymph node.
Left node core biopsy shows residual nodal tissue, however extensively infiltrated by this tumor. GATA3 can strong positive, supportive of breast primary. Repeat biomarkers in the core biopsy. ER 8/8, PR 8/8, HER2 negative, score 0. Thus, positive for metastatic carcinoma of breast primary, GATA3 positive, luminous subtype.
انا ليه كومنت بس بعد اذنك. معلش، طب هو حضرتك هو الفاين نيدل احنا ليه عملنا فاين نيدل؟ يعني اوريدي عملنا اي ار وبي ار وهيرتو نيو، وهي اوريدي عندها بالبيت سي تي هو جاست سنجل ليجن في وان بريست، فهو اوريدي شور ان في فاليسز موجوده في الفاين نيدل، فبالتالي انا عرضتها تاني الكور بايوبسي والاميونو هيستو كيمستري تاني، وفي الاخر طلعت نفس اللي انا متوقعه من البدايه.
To the pathologist, how reliable FNA to do ER, BR, and HER2 on it? How reliable?
It's reliable if positive. It's a good positive test, not a good negative test. So I am doing it to save the patient to do another procedure, invasive procedure. So if it's positive, I will report it as positive. But if negative, I will give a comment that we need more further confirmation by true cut biopsy to avoid fallacies in false negative patients. So it's a good positive test, not a good negative test.
In this case, it's already positive.
Yes. Yes.
هي ER and PR and HER2 all markers are not recommended on cytology in general. It's best to do it, and that's why I said from the beginning we would actually prefer to go for a core biopsy. It's much more reliable. Fixation is better. You have the tissue. You have the architecture. You can do immunos even to check if it is metastatic from breast or something else. So core biopsy definitely is best for immunohistochemistry, and there must be something technical about this. Maybe, maybe the fixation that made it fail.
Just a question from me. We say breast cancer is a heterogeneous disease. Have we ever seen lymph node metastases with a different receptor from the main primary core biopsy being a heterogeneous disease?
يعني actually this case is a difficult case to manage as a oligometastatic or double primary metastatic from another disease. So the confirmation of the final pathology on a TrueCut, I think it was very important, not on the fine needle, to confirm that we can go for the concept of oligometastatic in nodal in the posterior triangle disease.
يعني
this
sometimes
is very
radiologists in the MDT they refuse the true cut from especially the cervical region, so they ask for the fine needle. هكمل بس حته الباثولوجي ان هي طلعت الاي ار والبي ار نيجاتيف، فده احنا محتاجين نتاكد يعني ليه ترو كات تاني، عشان احنا محتاجين نتاكد انها من البريست، لان الجاتا 3 بياخد في يعني برايمري اوريجينز من حته تانيه. بس فعلشان كده احنا عملنا الترو كات.
طيب انا I would agree with your radiologist at the start ان هي FNA، لان انا عندي معطيات في فاكتورز البيت نيجاتيف، مفيش chance ان other primary احنا already مش it will not going to alter the treatment، لان هي اصلا already هتبقى احنا بس just to prove is it metastatic or not. so tumor cell في malignancy ولا، وزي ما طلعت positive it's positive خلاص done. فانا انا بس عشان الرساله ان هو ما يبقاش كل الليمف نودز هنعمل لها كور بايوبسي. انا بعمل كور بايوبسي كويس جدا في الاكسيلري ليمف نود بس والسوبرا كلاف، لكن لو if it will not alter in the treatment plan او the decision بتاعنا why to go with core.
So I think the question is can we go for the concept of oligometastatic disease in approved cervical lymph node metastasis or not? A single cervical lymph node positive, can we go or apply the concept of oligometastatic management with a curative intent?
Or we still consider it local regional disease?
طبعا دي اعتبرها دو نوفو oligometastatic وكيوراتيف انتنت كل اتمت.
I think in the oligometastatic approach will usually focus about the bony metastasis, the best outcome, and sometimes a single visceral metastasis. But the nodal disease in the cervical area, it is an another issue. So I think we exhausted our resource to confirm it's metastatic or not at single node mets or not.
كلنا موافقين احنا يعني you all agree that we will consider this as an oligometastatic disease. So we should start with the systemic treatment, I think, not going to the surgery. What type of systemic treatment? The same fights.
But this patient is a premenopausal patient, Dr. Amani. She's premenopausal.
I agree that patient has oligometastatic disease, but also she has a locally advanced high nodal burden. So it's not a T1 disease with N1 disease and single mets in the everywhere. We have a high burden disease with confirmed metastatic ductal carcinoma, ER/PR positive. We are in a way to give her a good systemic treatment of hormonal treatment. Even if it can be treated locally by surgery after then, but don't forget the patient needs systemic control to maintain response.
Hormonal. يعني usually we have what's called high grade palliation. High grade palliation, you treat the patient with curative intent, although you know this patient may not be cured. And this is the case in this case. Presence of N1 is not N3, this is M1. But being a very small lesion, which can be easily covered by radiation therapy, later on, I will give her radical, like any non-metastatic patients, neoadjuvant chemotherapy, followed by surgery, followed by radiation, and the same, I will add CDK4/6 as an either adjuvant or you extended adjuvant after that.
طب مين موافق على neoadjuvant who will go with the neoadjuvant chemotherapy?
Yeah.
Okay. And then neoadjuvant hormonal, pseudo neoadjuvant, not neoadjuvant, hormonal, Dr. Saleh. Okay.
But the difference between the two, this case and the previous one, but I just need to highlight the previous one with a postmenopausal lady and this one with a premenopausal lady. Will that alter the systemic therapy type for you? Is it valid that we use hormone therapy as a neoadjuvant if we decided to go here? Is it really accepted in the premenopausal setting? I'm talking about the menopausal status. I thought the guidelines saying that you cannot do that with a premenopausal. But we decided to treat her now as almost local regional rather than metastatic. Yeah.
So from the surgical point of view, Dr. Ashraf, after the systemic treatment, whatever it is, systemic chemotherapy or hormonal treatment, we'll go for local control of the posterior triangle lymph node or not?
I am asking about this. يعني you can guarantee the response to chemotherapy, especially in this luminal case. And so if يعني انا توقعت خلاص ان هي استجابت. اوكي وفي ريسبونس. Do you prefer ان انا اشيل كمان السيرفايكال lymph node or not? Even لو البيت سي تي فري.
A single posterior cervical lymph node for local control with surgery or with radiation therapy.
Yes, radiation therapy. I prefer radiation therapy, not for surgery.
So, Dr. Kobiker.
It will depend on the response. If the response is good and the node disappears, I would go ahead with radiation to the neck. If there is a residual node seen in the neck, then probably go for a neck dissection before radiation.
So, Dr. Ashraf, I think we have to confirm if there is residual viable tumor or activity on the posterior cervical lymph node, you can control with radiation therapy only?
I think we need to treat the single lymph node, not the neck. It is an oligometastatic disease. So the concept to treat only the gross disease, not the area. So if there is a complete response, I will not treat the neck at all. If there is a residual in the lymph node, I will go for surgery or SBRT, not neck irradiation.
Being in the neck, you can extend the supraclavicular field to cover this lesion. It will not a difficult process. You will do that, especially in cancer breast. If you have, a week ago, I have a cancer breast with single metastasis in DV2. So what I did, I treated the breast itself and I added the post dose to the vertebrae.
Ask Ahmed, another clinical oncologist to comment
Well, actually, the expression oligometastatic disease, the difference between oligometastatic and just metastatic case, that's there is potential of cure. This is the meaning of oligometastatic. It's not just number; it's how we're going to treat. If we're talking about oligometastatic disease, this means that we might go for a further surgery. We can try to cure these metastatic sites. So, especially with the cervical lymph nodes, I would recommend to consult radiation oncologist. Sometimes it's technically almost impossible to treat this node with radiotherapy, depend upon the site of the node. If the node it's very close to the supraclav, the fixation of the head sometimes it's really difficult. So it's better to know where the node exactly, because it's not just covering the whole area. We have to provide. We are curing, so we have to provide high dose radiation. It's not just we are offering the same radiation. We might need to push this node as well. So we need to evaluate if it's a high cervical, because the head in general something
Can
technical.
I come in, Ahmed? We have the privilege of having Professor Ayman Abdul Wahab معنا هنا. We all know the big name in head and neck surgery. I will hand the microphone to him.
Thank you very much. I'm enjoying the discussion. Maybe from a head and neck surgeon, I have been confronted with such cases. When I see cervical lymph node mets from the breast, usually I think about not an oligometastasis. It's usually it's more than one lymph node. And remember that for the head and the neck, if you want to get the lymph node, it's just a biopsy. So if you want to manage the head, the neck, you say you will go modified radical or selective neck dissection or radical neck dissection. And usually I reserve this when the patient ended his treatment, systemic treatment, ended his local treatment on breast, and finished the adjuvant treatment, and he's stable, and the only one last is the neck. I go for what kind of neck dissection according to the extent of the node, and maybe later on to get adjuvant treatment. And usually more than single lymph node. I even saw metastatic node to the thyroid gland, breast metastatic to the thyroid. But this is usually our.
I totally agree with Dr. Ayman in lymph nodes, radiotherapy with covering the supraclav and to extend to include the cervical node with the mobile head. It's almost technically it's not going to be very accurate. We can't deliver high dose. So I was going to suggest this after finishing the systemic treatment, we should consider surgery if possible, if we're curing. But with ablative dose radiotherapy, sometimes it's difficult.
So the net would be put on the side now and go for the primary treatment, whatever it is, and then we address later when she's completed all her therapy to the.
It should be an MDT decision. If there is a possibility for surgery after radiotherapy, we might do this as well if we're curing.
So I think now we will go for local control, either by radiation therapy or after systemic. Surgery.
Advantage أحسن tissue. It will take tissue. This case needs tissue for further verification. Better than radiotherapy.
I have a question, please.
You open an area of debate about even in single supraclav.
I have a question, Dr. Meher, for surgery. In daily practice, is infraclav and supraclav is excisable lymph node by surgery, even after response?
This is my question.
It's my question.
Muhammad. So usually we have a local control with radiation therapy, but in this clinical case scenario, we have a local control with radiation therapy to the area irradiated in this situation with the chest wall and supraclav, infraclav. But the posterior triangle lymph node, I think as Dr. Ayman mentioned, we can go for selective excision of the residual positive node. Okay, so after systemic treatment, we can go for the concept of oligometastatic disease in this clinical case scenario, and we can manage. So I think in every year, the concept of oligometastatic disease is growing up, even in the nodal approach or the contralateral axilla, and in the visceral approach. And also, I think we have another case about the bony, but there is a short time. So I think the final decision of the MDT was to conclude this case and to close it.
MDT decision for clipping over main lesion, then neoadjuvant treatment, reassess by PET-CT, then for wide local excision and axillary clearance. Patient already received neoadjuvant chemotherapy, EC 4 cycles and taxotere after clipping, then referred for surgery. PET-CT first.
Okay, the follow-up PET-CT was done, and this revealed marked regression regarding the left breast malignant lesion and the left axillary supraclavicular and also the lower posterior triangle FDG avid nodal deposits.
Two wires were introduced over the upper outer quadrant lesion and retroalar microcalcification, then for wide local excision and axillary clearance.
الريزيدوال tumor viability كانت around 60% وكان في evident therapy response fibrosis and hyalinosis. lymph nodes كانوا positive 40 out of 45 lymph nodes with extra nodal extension. مش عارف.
Why we wiring the retroareolar microcalcification, which is benign by MRI, no enhancement, and by
the patient will go for
pathology.
surgery, so it's a calcification finding, so we can clip it and remove it. By the way, it's a double confirmation, as you see yesterday, the microcalcification and fibroadenoma that changed the DCIS. So complete. Continue.
ماشي final result residual invasive duct carcinoma grade 2 YPT1C and 3 tumor viability 60% RCB 3 margins free lymph nodes 40 over 45.
Okay, I think we discussed this point about the adjuvant, and I think thank you for all of you about the 2 exhausting days, and very special thanks to our younger doctor for the excellent presentation today and yesterday and the preparation of the MDT cases. And
and again, my last comment to our younger colleagues, the discussion is how to think and don't just look at one aspect of the patient, look at everything, and there is no right or wrong. Everything is right, and we always trying to choose the best of them. Thank you very much.
شكرا لكم جميعا. ختام المؤتمر.